side at the New England Mental Health Technology Transfer Center. As Michelle said earlier, please feel free to introduce yourself in the chat box. Now, I just want to review a few housekeeping items before we begin. Participant microphones will be muted at entry. If you have any questions during the event, please use the chat. This session is being recorded and will be emailed to all participants once available. If you have any questions after this session, please email newengland@mhttc.network.org. At the end of the month, we will send you a certificate of completion that you can submit to your particular board of continuing education credit. Please contact iFisher at c4innovates.com for more information on CEs after the event. This following slide, it just provides a description of our disclaimers for MHTTC. And the MHTTC network is an affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive, and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. And with that, it is my pleasure to hand it over to Dr. Michelle Friedman-Yakubian.
Thank you, Ikra, and thank you all for joining this webinar today. We're super excited about this topic, and I really appreciate being able to see so many of you here spending your lunchtime with us, and especially love it when people decide to keep their cameras on because it's so nice to see the folks that we're speaking to. So I'm Michelle Friedman-Yakubian. I'm a clinical psychologist at the Beth Israel, part of the New England MHTTC team and the Massachusetts DMH. And this is the third part of a webinar called Psychosis-Informed Care in Community Outpatient Settings. This series is designed to help clinicians in the community outpatient settings by providing practical training and answering common questions about working with individuals who experience psychosis and their families. Each webinar features role plays and case discussions to illustrate common challenges. And today's focus is cultural considerations when working with individuals who experience psychosis. We have two fantastic speakers and a third team member who's participating in a role play. So it's my pleasure to introduce Vera Muñiz-Sorey, who is a non-binary queer Peruvian public health professional working as a program coordinator and peer advocate for the Massachusetts Psychosis Prevention Partnership and building bridges towards equity in psychosis intervention and careers grants at Beth Israel Deaconess Medical Center. They also serve as a peer counselor at McLean Hospital's lab for early psychosis. Diagnosed with schizoaffective disorder and a survivor of conversion therapy, Vera's work focuses on harm reduction, re-indigenization of academic knowledge, and dismantling oppressive systemic structures. Joshua Sabrina Chang is a psychologist, instructor at Harvard Medical School, and site supervisor for Boston University's Center for Multicultural Training in Psychology. A first-generation immigrant and Asian American woman, she has published extensively on cultural psychology and gender-affirming care. She provides culturally responsive anti-oppressive therapy and supervision and founded the Anti-Racism Task Force at the Massachusetts Mental Health Center. Her community advocacy has earned her recognition from the Massachusetts Senate. And Joey Rodriguez is a clinical research assistant at the Response to Risk Research Program at Beth Israel Deaconess Medical Center. A recent graduate of Northeastern University with degrees in psychology and philosophy, Joey has contributed significantly to the Mental Health Technology Transfer Center, developing training content, including an online course on coordinated specialty care, a podcast on culturally responsive care in early psychosis, and the Psychosis-Informed Care series. It's my pleasure to now turn things over to our speakers.
Okay. Hi, everybody. I am so glad that everyone is here, and thank you, Vera, for setting this up for me, the slides. I am very thankful because I am going to assume that you are all here because you care and you're interested in culture responsive anti-oppressive care, which is really the first step. And we're hoping that at the end of our hour today, we can turn that care and interest into a larger knowledge base and additional tools in your toolkit to do exactly therapy in this fashion. So next, please, Farah. These are going to be the objectives of our hour today that hopefully will serve as a map in sort of how we organize our time together. So starting off with the first objective, Farah, next, please. Thank you. I would like to first off, define what culture is. And it's really important to say right off the bat that culture doesn't just fall along racial and ethnic lines. Really, culture is any a culture is any sort of meaningful group of people that share an identity and share a way of life, transmitting different knowledges, norms, languages to each other and future generations. And so we can think about culture as a group of people who share a certain gender identity, sexual orientation, SES status, immigrant status, and so forth. So the list is really infinite in this way. So three things to know about culture right off the bat is that it's always changing. And so one thing you might know about culture may no longer be true 5 years later. So for example, the pandemic and the hate crimes that ensued from that has fundamentally changed, I would argue, the Asian American culture from 2019 to now. The second thing to know about culture is that right now in the world that we live in, we're probably all multicultural selves. So understanding intersectionality of identities is really important, and to really consider culture as multifaceted when you're sitting across from somebody, especially in therapy. And next, please. Thank you. And the last thing about culture is that it's everywhere. It's showing up right now in the way that I'm speaking with you, in the way that I'm dressed. It would be really strange, for example, in our culture's definition of professionalism, if I were to show up in an evening gown right now. So culture is very much influencing, impacting our interaction right now. Next, please. Thank you. And so, and don't just take my word for it. There's a lot of research that in the last 100 years that have bared out the fact that what folks used to think as universal across our species are now really understood now as culturally bound phenomena. And next. And so I'm just going to throw this slide up here to illustrate that some of these, what we thought were sort of basic fundamental human processes, are now understood to be culturally bound. Next, thank you. Okay, so if humans are highly cultural, it means that anything involving humans would be a highly cultural process, including therapy. So just to maybe involve you guys right away, I'm wondering if you can just throw out some ideas. Feel free to unmute your mic if you like, and let me know what do you think are some ways that culture shows up for you when you sit across from a client. I actually don't know if we can unmute our mics. I'm not sure if the technical aspect allows.
You can unmute your mics. You have that
Cool.
power, so feel free to do so. And folks also have access to the chat if they want to put some ideas there too.
Okay, awesome. Yeah, so I hope that by thinking about this question, we might come to a realization that it's actually really hard. It's harder to think about um, aspects of therapy that are not impacted by culture, and that the ways that culture shows up in the therapeutic process, it's really infinite. So the idea is not to come up with an exhaustive list of the ways, but to really think about the entire process as cultural. And I'm hoping that's the mentality that we can hold for the rest of the presentation today. Thanks, Farah. Next, please. So I want to highlight that cultures not only differ in terms of how we think about family or relationships or emotions and motivation and so on. One really important way that cultures differ in our society is by how much power and privilege they hold. And so there are absolutely cultures in our community that hold more power and privilege, and therefore more oppressive than others. And so this is important for me to highlight because already in a therapeutic relationship, the therapist and the client are entering a relationship where they are not holding the same level of power. And that can get exacerbated by the therapist holding identities that are bestowed more privilege and power in society. And so the idea is behind anti-oppressive care is how do you hold more power without being oppressive? How can you essentially carry a big stick and not be oppressive? And so the idea is we can't let go of the stick. The stick is there, but how can we essentially share that stick, if you will, with our client? And Farah is going to launch into doing that into some skills on doing exactly how to do that. So take it away. Thanks, Farah.
Course. Thank you so much, Joshua. Yeah, so we're gonna get into some specific skills for building cultural understanding. I know that the title of this presentation was on cultural responsiveness, but we'll get onto how that connects to the larger, broader concept of cultural understanding. For now, I would like to open up the idea of understanding and responding positively and with full recognition of the cultures that somebody brings into a room, as like the idea of like having a toolbox. So cultural understanding is the larger toolbox, and I would say cultural responsiveness is one of those tools that we can take out of that toolbox to like help us in our interactions with others. So one of the first things that I think we usually learn in professional situations is the idea of cultural competence. Navigating interactions competently has been a large focus of like American professional standards for a while now, particularly when it comes to like corporate standards of like what it means to interact in a diverse workplace environment. But cultural competency as a concept by itself is fairly limited. Cultural competency is usually emphasized as a body of knowledge that you build up. And once you have a full understanding of what it means to interact with diverse cultures in a single space, is usually seen as sort of like a one-size-fits-all approach to like approaching people of different cultures. I would like to posit that cultural competency is just one of many skills that we should be incorporating when we develop a more holistic idea of cultural understanding. And that cultural competency on it by itself is not sufficient, and is usually only enough to make note of and recognize explicit actions of discrimination, usually explicit acts of racism, explicit acts of homophobia, transphobia. And so when we're building up our toolbox of cultural understanding, when we think of the scale of cultural competence, I think it is a lot more productive to think of it as sort of a set of a ideological and ethical principles that we bring into our interactions with others. So very much in in this area of the toolbox, I would say that one of the most important skills is learning to be anti-racist. Being anti-racist does not mean just to not actively engage in racism, to not say racist things, to not engage in racist systems, but also to make sure that you're noticing things like microaggressions or assumptions or things that may be more implicit in your own ideology and attitude that may be affecting your interactions with other people. Some of the most important things in this regard are to not make assumptions about someone else's experience, to avoid dehumanizing language, and that includes slurs and euphemisms, Something that in the industry that has been very commonplace for a while has been using euphemisms like somebody being a problem patient, or using the idea of being low functioning, which is not a very efficacious label, or using things like IQ, which is not a very efficacious measure, as a way of labeling somebody as requiring specific needs, when we could be using a more needs-based approach to describe like what sort of supports they actually need to go about their day-to-day functioning. And even like labels like non-compliant or like having an attitude problem can be used particularly to marginalize people of color in treatment settings. In treatment interactions, another thing that's becoming increasingly important to be aware about is using language of the people that we serve. We have a growing amount of peer professionals being incorporated into the field, and as a larger industry, it is part of our natural trajectory of our industry to start incorporating more lived experience of people who are consumers as well. And part of that is also making sure that we're incorporating consumers that are not just people who hold privileged identities. People who hold multiple intersecting marginalized identities also need to have the space to be able to set the language that they use in sessions, as well as like when they interact with any aspect of the industry. And of course, a big one is avoiding security, police restraints, and legal involvement, other responses that limit a client's autonomy or the autonomy of the people that we serve. And having in the back of our mind constantly when we think about using these specific responses, if there is any alternative way to keep the people that we serve safe, is there any potential risk to the people that we serve when we engage in these responses? And does the person that we are trying to support have identities or a history that could make the type of response that we're engaging in be potentially traumatic? And of course, one of the major things that we also have to be focusing on is seeking to actively acknowledge and learn about the history of social harm and cultural harm that has been perpetuated by the mental health system. Speaking as far back as like the Hiawatha Asylum for Insane Indians, talking about like the Danvers Insane Asylum in Massachusetts even, and the long history of lobotomies and electroconvulsive therapy used on people who experience psychosis and queer people in our state. So, cultural competence, I feel like very often makes us feel like we have to be policing our behavior, as if we have to constantly be aware of potential interactions where we may be acting with bias or may be acting with some sort of socially ingrained behavior that we may not be aware of that may be reinforcing bias. And that's where cultural humility as the second skill in our toolbox is going to be super, super important. Cultural humility, as defined by Wheeler and other researchers in 2018, is an ideology that builds upon the idea of cultural competence. Cultural humility is more ideological and less procedural. So more often than like having specific steps or checkboxes that we should be thinking about in terms of cultural humility, we should be thinking about how is it that we're building our ideology and how are we developing the ideas that we use to inform our practices and professional behavior. And so cultural humility is defined specifically through a culture of openness, self-reflection and awareness, lifelong learning, institutional accountability, empathy and compassion, being other-oriented, which means to approach interactions with openness, respectful curiosity, lack of arrogance, and genuine desire to understand, and acknowledging and balancing institutional power imbalances. So this is not just within culturally responsive care within the care setting from like care providers, but also within the institutions and the workforce that we are bolstering within our industry as well. People who have institutional power, especially when it comes to like large institutions with a lot of influence over support systems and the ways that people seek out resources that they rely on to survive, have a socially ingrained responsibility, or rather a a social responsibility rather, to acknowledge those larger power imbalances and to correct them when they come up. And part of that is sort of building the third tool in our toolbox, which we're about to go over, which is cultural responsiveness, responding to feedback. So part of what is a feature of the peer specialist movement, of being a certified peer specialist in Massachusetts particularly, is this idea of coming from a space of mutuality. And that generally underlies a lot of peer support interactions. And so increasingly, I think it is very important that we think about this ideology, this ethic, and this practice as we are moving forward in our field, as well as synthesizing it with things that we learn from like treatment modalities that have been developed by people with lived experience, like Marsha Linehan. And I have my own criticisms of Marsha Linehan and DBT as a modality, but I do think that this skill can be a nice, handy way for understanding how people feel most validated when they have a provider responding to their feedback. So when somebody is giving feedback, whether it be of a practice, of an institution, of an individual, or of a clinician in session, it is important that we be gentle, act interested, validate what we are hearing from this person, and use an easy manner. The give fast skills in the DBT manual are the most stretch of an acronym, but I do think that it helps to memorize a little bit because I think because it's so much of a stretch of an acronym, it becomes a bit of a mnemonic in and of itself. So it's very important that we are not meeting someone's own feedback as if it is criticism. Defensiveness and willfulness can be a very common response for people in privilege when they are actively asked to reflect upon the ways that their privilege is affecting the way they move through a space. And that is something that can come off as particularly harsh to someone who may be trying to advocate for themselves, particularly with somebody who has multiple intersections of marginalized identities, who may already have difficulty advocating for themselves because they may feel as if they don't have the space to. Being actively interested in how a person is giving that feedback is particularly important, making sure that you're reflecting back to them, asking clarifying questions, and making sure that you fully understand the content of what they're trying to convey is extremely important. And also to make sure that you recognize that you have shortcomings as a clinician. Very often, in medical interactions, there can be an idea of an inherent power dynamic between a clinician and the people that they serve. And because of that, it is particularly important that people in power, clinicians, people within treatment structures are actively validating the experiences of their clients. It can be very easy for people who don't have a grounding in the field to believe that a medical professional or a mental health professional will automatically have more knowledge than them. And so to actively counteract that, clinicians, providers, and professionals in this industry have to actively make sure that they're letting their clients know that their concerns are not trivial, that what they're experiencing is real, that what they experience is valid and worthy of consideration, and that as clinicians and providers and professionals, that we are working with that feedback. And of course, using an easy manner. Being very intense about feedback and being very prescriptive about ways that somebody submits feedback and being very intense about the format in which somebody submits their feedback can really actively discourage somebody from providing that feedback in the future. And this goes for clinical interactions as well as for structural professional workplace interactions as well. If there is a large idea that the environment is tense or that the idea is not open to criticism or that there is tightly ingrained institutional power that avoids any sort of structural change, then any feedback going forward will be harder and harder to actually solicit. And so I have this little diagram sort of to just sort of sum up the thoughts from the past few slides, but cultural understanding is a larger skill set. Cultural understanding is something that we should be striving towards. And there is not one single skill that somebody can practice that will make them always act actively professional, culturally competent, culturally humble, culturally responsive, and be fully ultimately effective in that interaction. It is not just one of these skills that we have to build. It is not one that is inherently better than the other. It is very much that we have a large toolbox that we have to actively be adding to. And the thing that's super important about this is to understand that we have a finite space in our toolbox, but an infinite amount of information that we have to learn. So there's inherently going to be a lack of understanding, a lack of a complete understanding that everybody brings into any cultural interaction that they have. And so it's always important to make sure that we are approaching that with as many tools as we have as possible. These three tools are the main ones that I would say that the industry focuses on and that I think are largely the most relevant to our work as people in the mental health industry. But that being said, that there's a lot more to cultural understanding than just prescriptively learning these three skills. It's also about being ingrained in community and understanding movements and understanding larger historical and cultural trends. So that being said, I am going to go ahead and pass this back off to Cheshwen, and we can move on to our final points and our role play.
Thank you. So maybe to to kind of wrap up our presentation, we want to have a very clear take-home message, which is that in order to be culturally responsive and anti-oppressive clinician, it's a lifelong journey, because that means you have to be a culturally responsive and anti-oppressive human. We will posit that it's pretty much impossible to be culture responsive and to oppressive 9 to 5, Monday through Friday only. This is something that you would have to embody. And so I think that journey starts with a decision, the intentional decision to choose either to be active in taking a part and a helpful role in liberation and empowerment of marginalized communities, or to be complicit in oppression and marginalization. So if you do choose the former, and you would like to take an active role, and you would like to continue working towards becoming an anti-oppressive and culture responsive therapist, we have some tips for you. Next, Vera, thank you. Awesome. So we would recommend that you would start with some solo work. Just work by yourself, taking time to really reflect on your own biases, including the implicit ones, as well as your privileges. And as part of that process, really take time to be up to date on scientific literature on what is the latest on culture responsive care. But don't stop there, and also make time to engage with media that really centers and traditionally disempowered voices. And that could be through the medium of your choosing, whether it's blogs or podcasts, whatever you like. And so once you've done that solo work, then it might be helpful to now take a more interpersonal approach. So think about what are some ways you can practice having difficult conversations with your friends and family instead of avoiding them. And when oppression unfolds in front of you, because it will, um, really practice how to disrupt those moments in a way that's empowering for the person that it's impacting. Um, in addition to that, I think it's really essential to surround yourself with people who are different from you. And so actively fostering and valuing relationships with those individuals. And during the course of those relationships, if such individuals are willing to offer you some insight into your own biases and prejudices, to see if you can respond in a way that's curious, fosters even more understanding, and also finding a lot of gratitude for that person who's willing to get out of all of their responsibilities to take time to teach you about something that will help you become the anti-oppressive and culturally responsive clinician you want to be. And lastly, I think it's really important to get involved in the communities that you're serving and really understand what are the issues that are currently impacting those communities. And so a note here is that the way to show up would be to be an accomplice, to help, to be a pair of hands, but not to use that to then find yourself a platform to speak on behalf of those folks. And so those are some hopefully helpful practical tips that we encourage you to start implementing and experimenting with. And with that said, that's the end of the presentation part, and we're going to go into the role play. Okay. So, should we just launch into it?
I think so.
Okay, awesome. All right. Okay, so we're going to start off by role playing the not so great version. And the idea, the setting here is this is a first session with a client after the assessment. Okay. Hi, Joy. It's so nice to meet you. Thank you for being here. You made it to your first therapy session. Um, what can I help you with today?
Yeah, I'm kind of nervous, but I'm excited to be here too. And I don't know. That's kind of why I'm here in the first place.
Okay, well, maybe tell me about what's bothering you the most then. Well, what's impairing you the most? Let's start with that.
I mean, I don't know. I guess I've been feeling really uneasy, like in general, and at church. I don't know. I go to this church and people are just like looking at me, like just judging me for just the things that I am and that I yeah, just who I am as a person. And it sucks because it's like a big part of my life. Like my family and friends go there. Um, and they're also, yeah, they don't really subscribe to the way that I am.
Yeah. What do you mean by the way you are?
I'm queer.
Okay. Oh man, that sucks. So you are at a space where it's like it's not queer friendly. And that's got to be really hard. So, I mean, have you thought about just like going to another church? I mean, there's so many progressive churches out there now. And they would love to have you, I'm sure.
Yeah, I don't know if I feel comfortable going to like usual churches. I don't know. Yeah, I don't know how to say it without sounding rude. Like I just feel like it's like pretty white. I feel like everyone would kind of be looking at me there and it wouldn't be the same.
Oh, wait, so so are you saying that you would also feel kind of paranoid and anxious in like other places too? So in other churches as well?
Yeah, I guess.
Oh, okay. So seems like then like this paranoia piece is really the problem here. Joey, are you still on your medication?
Yeah, I mean, I don't know. I try to take it when I can. Like I know it's helpful and I should be taking it. I don't know. I'm not sure if it's worth it, but also I don't know if it has anything to, I don't know. Yeah, no, not, I mean, a little bit, I guess. I don't know.
Oh man, so okay, so you're not taking your medication really, and I'm really worried because I mean this is our first time meeting, but I mean I did my homework, I read your chart, and I know that every single time you've gone off your medication, you've decompensated, and so I feel like we really need to like help you by getting you back on medication.
Yeah,
That's probably
yeah, I'm aware of that. I don't know. Medication isn't even what I'm here to talk about today, though.
end scene.
Seeing.
And yes, thank you. Okay. So I think we got some feedback. I just saw in the chat during it that people couldn't see our faces very well, and then we changed the format. Was that better? Hopefully that was. If you want to give us an update, that would be helpful. So if folks can feel free to unmute yourself or use the chat if that's easier. If you can give us your impressions on what went wrong in the last 5 minutes.
Think there was a jump
Hmm.
or pathologizing language or not connecting with the language they were using, like paranoid as opposed to distress, or I can't remember the exact word, but yeah, jumping to more like clinical language.
Absolutely, yes. That can feel really alienating.
There was like
stuff in the
Yeah.
chat.
Well, I think Madison, you were gonna say something?
Yeah, I was just gonna say, there was like a strong focus on like symptoms, even though it felt like Joey, you were trying to express a lot more about your feelings within your church community, and like the automatic problem solving went into like, we'll switch churches. And then from there went into a focus on the symptoms. And then from there, a focus on the medication, which felt kind of counter to everything it seemed like you were trying to talk about. So focus again on like the pathology and all of that, like the person before just said.
Yeah, I thought that was really insightful, Madison. I agree. Almost as if like there was an agenda being prioritized outside of the concern and the prioritize of what may have been the needs of the person in given what they have disclosed so far.
And I'm scrolling through the chat, and yes, thank you everybody for your feedback. And we're going to, if there's a good pause here, what we'll do now is transition into the next version, and we're gonna try to. Oh, I'm gonna try to do better in this next version. Okay. Awesome.
Okay, you ready, Joshua?
Yeah, let's do it. Okay. Hi, Joy, you made it to your first therapy session. I'm so glad you made it. And if it's okay with you, I would love to start off by getting to know you better. So, what are some things you feel like would be important for me to know about you right off the bat as we start to work together?
Yeah. Yeah, I'm looking forward to this session too. I'm pretty nervous. But I'm also, I'm here for a reason. Yeah, I guess just keeping it simple. I'm Mexican. I love being Mexican. I'm like, proud to be Mexican. Um, from a Mexican family. I'm queer and I love Jesus and I follow him and I think he is. I try to live by him and his words as much as I can.
Thank you so much for just taking that question of mine so seriously and sharing so honestly with me about you. And I'm listening to your identities, and I'm thinking about then how it might feel like for you to show up here in this building today and to be talking with a therapist. Because man, the mental health profession, like we've really harmed people that identify as you in really, really awful ways in the past. And I just wanted to check in. Well, what's it like to be in my office right now?
Yeah, yeah, scary. Just reminds me of something my mom's side used to always say. They have like the expression is if I'm gonna tell my deepest, darkest secrets to some stranger just to have me like thrown in the like like I know it's not the hospital or like the whatever with everyone else who like couldn't figure it out like they're not gonna get me too, so stuff like that. So yeah, it's scary. Like I'm the first one to come here, so yeah, it's kind of scary, but I'm also like here for a reason.
You're so right, Joy, and I appreciate you talking already about the inherent power imbalance in our relationship. You're right. You're coming in here, and the way therapy is set up in the Western world is that I hold more power than you, and that's scary. That's terrifying. And so you're really taking a risk by being here, and I'm gonna work really hard to make sure to do my best to make sure that that risk taking pays off for you. Um, and I'm just wondering if there's anything I can offer about who I am as a person, or if there's anything more you would like to share with me at this point to build our relationship, or if you would like to, yeah, if you would like to pivot to something else.
Yeah, I thanks for saying that. I can't think of anything right now, but I'll let you know if anything comes to mind. It probably will be. I I don't get it. I don't know anything about you. I don't know what you value. I don't know what you find most important in life. I don't know what you believe in. Um, but yeah, I'll let you know if I think of something.
Yeah. I can definitely appreciate that, because I think just already us sitting across from each other, you can see a lot of ways that I'm different from you. And so I it would be completely normal. It would be odd if you didn't actually feel some level of discomfort sitting with me and some worry and anxiety about whether I'm going to be able to understand you or not. And so I appreciate you sharing that with me. And yes, let's continue having conversations. I think I would love for us to be able to not just talk about what's going on in terms of problems or things you want to tackle. One other thing that's going to be really important in the work that we do together is that we have a good relationship, and that means we really need to trust each other and get to know each other. So
Yeah, I mean, I usually only talk about like insider stuff with my community. So, or like inside, like, difficult things that I'm going through. Yeah, I only talk about that with my community. And people were like, oh no, you really should see a faith-based healer, but like I'm willing to see where this goes.
So again, another risk that you've taken. And I'm showing up as someone who really doesn't align with your identity in a really important way because I'm not a faith-based therapist. And so that tells me I'm gonna have to work extra hard to try to understand you and be actually useful in your life. And so thank you so much for letting me know what are some things I can already work on right off the bat as your therapist. That's so important. There's no way I can know that without you telling me. Um, is there, if you feel like there isn't anything else to share and there's nothing specifically you'd like to ask, I want to honor our time too by making sure that we have time to talk about maybe some of the things that's bringing you to therapy. So what can be something that would be meaningful for us to tackle today?
Yeah, I, I mean, I've been feeling really, like just really uneasy at church, at the church that I go to. Um, just speaking of like communities that I trust, I'm here because I feel like I can't go to a faith-based healer or anything. And just been feeling really uneasy. Like people are looking at me, like people are um like questioning me and my sexual orientation. Like I haven't came out yet. Um, and it's been getting like really in my head, and I haven't been able to like leave my head. Just feel, and it's been hard, like thinking that people are thinking about me behind their backs and talking to me. And it sucks because church is like a really big part of my community. My family and all my friends go there. But also like this church specifically, they use a term called like non-queer affirming or something, which makes it really, really hard. Um, and yeah.
That sounds really painful. And I can hear how in your faith-based community and your church, there are so many parts of you that feel affirmed and seen, and there are parts of you you feel like you have to keep hidden, and that's gotta feel really lonely.
Not really. I mean, it doesn't really feel lonely. It just makes me feel like alienated. Like it makes me feel like ostracized, like I don't belong. I don't know about lonely.
Joey, thank you. Thank you for correcting me there. I made an assumption and was way off base. So thank you for taking the time to address that. And I hear you. It's not loneliness. Are you willing to teach me a little bit more about your experience? I hear it's
Yeah,
alienation. And I would love to hear more so I can learn.
yeah. Thanks for apologizing. It's okay. Yeah, I can explain more. Um, like I'm not lonely. It feels like I'm on borrowed time with them. It feels like I can lose this community at any time if they were to find out about me being queer. That I can lose it at any moment.
Yeah, that's such an important distinction. That it's it feels like there's anxiety maybe that this community can slip away anytime. That's a huge distinction from feeling lonely. So I so appreciate you telling me about that, and that allowed me to better understand you. And seen.
Seen.
Seen. Okay, so what did folks notice that went better, or I did hopefully better this time around? All of it.
Janelle said all of it, lol.
Hmm. Okay, so maybe my tone? Yeah, awesome. Oh my gosh.
You apologized. Yeah,
Yeah.
that's something that we were really hoping to have stand out. It's that like you can't be a perfect person, especially on like the first day of, and you can build off of this, Joshua, but you know, it's not about what mistakes you make, but it's about what you do after them, right?
Mm-hmm. Exactly. And I'm gonna follow Vera's example and quote something from Marsha Linehan, which is that um, to be a good therapist means you're really good at apologizing. And so that's at least the spirit I was trying to honor in that role play. And I hope one distinction too that folks notice is that I didn't actually make it Joey's responsibility to start a conversation about our identities and culture and the history of harm and oppression that mental health profession has executed. I made that my responsibility, and I try to try to take that on and set the tone from the very beginning. So I think, and I appreciate all the flurry of responses. I'm going to definitely read over them and learn from your reactions because this is very much a learning opportunity for me as well. So I'm just looking at the time, and maybe this can be a point where we open it up to questions more formally. How does that sound to you, Joey?
I think that sounds great. Yeah, maybe we can take, looking at the time here, maybe take 3 questions.
Perfect.
And feel free to use the hand raising feature, y'all, if that would be easier.
Mm-hmm.
Or folks can ask about in the chat.
Mm-hmm. Yeah.
Abby.
Oh, I think we have one hand raised, Abby. Abby, is it okay if I spotlight you real quick?
Oh, sure.
Awesome.
Oh, come on, camera.
1 second.
Hi, all. Great presentation. So I just was curious. I feel like so often the onus on reacting, on calling out is on the person receiving services or occasionally on the team member with less power, which is the peer specialist or the non-clinical perspectives. So I'm curious to hear a little bit about how clinical providers can take this knowledge and use it to inform their relationships with each other and sort of forming that accountability between clinical providers and taking it off of those of us who have been psychiatrically labeled to offer.
I love this question. Um, I think that, and also hi Abby, good to see you. I think that there needs to be an updating, honestly, to like what we view as like standard clinical ethics. I think that there is for too long been an accepted level of paternalism within the industry that pretty much gives institutional power to clinicians to make large decisions that can impact large aspects of their clients' lives. And so like for me, the thing that the certified peer specialist certification I think was really helpful in learning about was learning about like peer support models that rely on the idea of like an assumed underlying space of mutuality and like approaching all interactions in that space of mutuality. I think that there needs to be a level of like recentering of autonomy as being something that we consider in our clinical interactions, because I do think that it's just been taking a back seat for too long in the industry, and I would say has not been meaningfully addressed yet.
And if I can add to that, thank you, Vera, is that I think one thing that we didn't completely have time to get into is how to be anti-oppressive at the workplace. And so outside of the therapy space, when you're sharing, when you're sharing information or you're in the middle of a team meeting, I think there are tons of opportunities to create a culture within your team where you can um, hopefully like teach your fellow teammates about how to be anti-oppressive and interrupt moments where they're being pejorative or I think it would you can't really be an anti-oppressive clinician if you're not doing that in the work setting as well. And so that's part of the practicing interrupting oppression.
Sort of as a little addendum to that, labor organizing is a huge aspect of like making sure that we create changes in our field. It's not just about creating policy change for like practices in like clinical settings. It's also about making sure that the workforce that we are hiring is actually happy with their jobs and how they're being treated by their employers. Oh, go for it, Sherry.
Hi, thanks so much. This has been really valuable. I'm grateful. And you guys mentioned that this is the third in a series, and I didn't get notice of the other lectures or webinars, and I'm wondering if there's a way to access those.
Hi
That's a
there.
great question. We'll be able, yep, maybe this is a question for
You're more
Michelle.
than
Let's put it on real quick.
Go for it.
Okay. Probably what Michelle was about to say is that yes, we can send you and we can list previous webinars. We can also send and put you on a list to receive future webinars. There will be 2 more in this 5-part series. And anything that you'd add, Michelle?
The only additional thing is I'm looking for links of the recordings of the first 2 that I'll put in the chat.
Thank you so much.
I'm also seeing some questions in the chat. First one that I'm seeing is, what about clients who are so guarded / preoccupied they can hardly participate in an interview? I think the question is like, how could you approach a clinical interaction like that?
I can take the first stab at that. So I think it's really important to meet the client where they're at. So rolling with resistance is something I think about. So yeah, if a client is so guarded that they don't want to talk about something, let's not talk about it. That you can only walk through doors that are open to you. And I think that's actually a really respectful way of showing up. So I think it's a balance between absolutely making space and encouraging clients to talk about things that bring them to therapy, and very much honoring the fact that they're not going to want to share with you right away. That makes so much sense. I was a perfect stranger to Joey. They didn't know me from anybody. So to provide a lot of validation, and so that they at least know, okay, well, I can't really talk to this person, but this person has some understanding of how difficult it is for me to be here, and the very reasonable place I'm coming from in terms of my mistrust.
I think that for me also when it comes to like peer support interactions, I am perfectly fine sitting in a space with someone for like an hour silently. If that's what they need, if they don't feel comfortable interacting with me directly, if they don't want to talk to me about anything necessarily meaningful to like the reason why they're seeking treatment, that's not my prerogative. As a peer specialist, I'm there to like give them the power in their hands and to advocate for their needs. So I am also perfectly comfortable just being like, hey, like, I noticed we've been sitting here in silence for like 15 minutes. Is that how you would like to use these sessions? Or do you want to like, we can listen to music, we can play a board game, like whatever would feel like most helpful and supportive to you. And I just kind of like try to meet people where they're at.
Yeah, I have lots of things in my office. So like drawing, I have like a whole coloring book, and I have lots of interesting things to look at together on the walls. So just in case that, that becomes that's maybe something that they're looking at, you can maybe express some interest in that. So just being creative, I think that's the best part of being, one of the best parts of being a therapist is that you get to be really creative, you get to problem solve. And be curious about other humans' experiences.
I'm seeing another question also from Ken. Pointing out history has negatively impacted people who share identities as the client. That's sensitive, but also is that coaching a certain response from the client? I think that in my own experience, I think that acknowledging the history of oppression can be done without necessarily saying that a person has directly experienced the type of oppression that we're specifying. So like specifically when I'm talking about like mental health counseling, I think a common experience amongst queer people is that very often like identities that we bring in may not be interacted with positively, or maybe disparaged, or maybe invalidated in some way. And so there's a way of acknowledging that sort of larger trend without saying that that is something that you assumed has happened to a client. So like for me, the way that I would approach it would generally be that like, I can understand that this industry and that therapy in general can sometimes be like really unfriendly to people with like our own community ties, or like who come from like the communities that you come from. And if that's something that you ever think about as like being really important to talk about in this space, I would really like to invite open dialogue about that and talk about it if it comes up. And also I'll do check-ins occasionally just to make sure that like we're checking the vibe. The vibe checks I would think should be encouraged, particularly when we're talking about like racial dynamics. There should be like check-in, not like every week, but like if it feels like there's tension, if it feels like there's distance happening in a session, it may be a good opportunity to be like, hey, is there something that's been going on in our session that maybe have been affecting our interactions, and like how can we move past that or through that?
Yeah, I really appreciate that question because I think that's a really common sentiment, and I think one thing I think about often in relation to that is how we handle suicide. So during assessment, you would absolutely talk about suicidal ideation, assess for risk, and that doesn't mean that you're coaching your client to think about that or to report about that. And so we want to take that similar approach to talking about oppression, marginalization, and cultural responsiveness in session. And as a clinician, what I really want to do is create a therapy space that hopefully feels fundamentally different from the one that our society creates, which is one of pretty much silence and like again putting the onus on the person marginalized to talk about the marginalization or to volunteer without even knowing that person is safe to begin with. And so I really want to counter that and create a space where I'm the one taking that responsibility and doing that, since I'm the one with the power in that relationship.
Thank you so much. Want to give a final huge round of applause for our presenters. This is a wonderful, wonderful discussion. So appreciative. We will have a recording of this available online in the next week or so and send that around. Thank you very much. And thank you all for participating in your wonderful questions and comments as well.
Thanks, everyone. Have a great week.
Thank you. It was wonderful. Thank you. Have a good one.